Recording.
Lovely.
Good. Okay, thank you very much. And back for the second part regarding the dish. So we went through these things. You know, the main point of the original score was to identify the responders and the non-responders, and the greatest majority of the responders by far had amplification. So in layman term, you have a lot of black dots. So these are, each dot is one hybridized HER2 gene signal, and the red dots are the chromosome 17 centromere signal, and that correspond to high expression, and instead something with low expression doesn't really have amplification of these things. And note that it's not just the number of genes that are there, but also the clusters, because that means they are in the same area of the genome. This is really amplification. So the location is also important. Okay, and this was, we went through it. I think we can skip all these and we can go on technical overview of the DDISH assay. So the DDISH assay has a silver in situ hybridization signal, which is bound to the probe that identify the HER2 gene. There is an amplification system with antigen antibody anti-DNP construct, and then eventually a silver signal. Silver signals are very fine, and that's why we see it in such a good contrast. The other probe is labeled with a red signal, which is a naphthol red, and naphthol red is coarser and it makes bigger blobs. And so we are less happy to call the two chromosomes 17 close together. It may still be a signal. You will see in the thing. So silver is very precise, and you can actually speculate that a blob that is a bit bigger, probably there are two signals. But in the red signal, not really. You need to be.
They can be of different sizes, very variable sizes.
And then also, I thought about this labeling for chromosome 17. It's a centromere probe. Usually, there is one binding region.
Yes.
And per chromosome. So if I have two signals, it could be that I have two chromosomes. But sometimes I have no signals, but there is still the chromosome 17 is because I've lost that centromere region. And sometimes there are multiple chromosome 17 probes, but actually there is only one chromosome 17. Yes. And this is just an amplification of this area. So to be interpreted a little bit.
Yeah, that's why the concept of polysemy, chromosome 17 polysemy, is quite controversial a little bit.
Okay, so this is the interpretation guideline that comes with all these reagent kit. This comes in a kit, but you need to understand that the interpretation guideline was made several iterations of the guidelines ago, and therefore it has these funny numbers, 1.8 and 2.2. This is all changed. So don't worry about the fact that there are going to be discrepancies between what the guidelines say and what your interpretation booklet
the final.
say. Yes. And I don't know whether this is current. Probably is current.
Yes, this is the last ASCO Cup updated guideline.
But so you remember ASCO Cup gave us groups 1 to 5, where group 5 is clearly negative, nothing to worry about, absolutely normal. Group 1 is clearly amplified. And then there are these intermediate groups, and the interpretation of the actions associated with these different groups has changed in the new interpretation. So in general, if you have a ratio between chromosome 17, HER2 and chromosome 17, more or equal or more than 2, you are in group 1 or 2. If instead is less than 2, you're in group 3, 4, and 5. And that's why you need the second signal to understand what, to calculate the ratio. So some people do in situ hybridization with a single signal, only HER2, but you will lack the benefit to understand how many copies of chromosome 17 there are. So the second magic number is 6. So if there are 6 or more copies of HER2 gene per cell,
You can call it positive.
you can call it amplified, even though there are no clusters. And we can have a little discussion about is it the same as having clusters? However,
yes. As far as we know, there are the main two guidelines is the ASCO-CAP and the UK one.
Yeah.
There are also others, but I think they're similar with one or the other, with the ASCO-CAP or the UK.
Yeah.
The main difference between these two guidelines is in this group 2, because HER2 path, if you're in UK, you are familiar with the HER2 path guidelines. They are saying if the ratio of HER2 over chromosome 17 is above 2, that means it is an amplified and you can regard it as HER2 positive.
regardless of how many
Regardless, exactly.
And why do they say that? They say that on the back of the data from the looking at HER2 in the neoadjuvant setting, so before surgery,
Yes.
and looking at the pathological complete response as a surrogate marker of response.
Yes.
So and they show that
There's no
tumors with less than 4, providing there is 2 or more ratio, they respond as
Similar.
They have benefit from this therapy.
Yeah,
So
with the-
they say we should call it amplified.
Yes. So as far as I remember, the HER2 path guideline came after the ASCO-CAP guidelines, and the latest one, which was 2024, if I remember correctly. And they are saying, we noticed that the ASCO-CAP guidelines, they are saying group 2. So ASCO-CAP guidelines group 2, they are calling it in the end negative. Even if the ratio is more than 2, if the HER2 copies are less than 4 per cell, in the end, they are calling it negative. So
On the basis that they cannot find evidence of protein
response,
protein overexpression.
And the responders are way less. This is their data.
Yeah.
While HER2 says, no, we are still calling them positive, HER2 positive.
And we need to understand that there is a fundamental difference in approach, because in the UK, which is where the UK data come from, first we do immunohistochemistry, and if necessary, we do in situ hybridization.
Yes.
In the US, there are a lot of places that do in situ hybridization up front. And then they say, oh, in these cases that is not quite certain, let's do immunohistochemistry afterwards. So the circumstances are different. Okay. And also, it could be that your local guidelines are not the same as the ASCO-CAP guidelines.
Yes.
Yeah.
So you need
So retune
and
to your local.
One more thing that worth mentioning is this group 4 that now it's aligned with the HER2 path. HER2 path let go the borderline not amplified. It's no longer such a category. And it's more or less the old borderline not amplified is more or less the same with the group 4, where they are saying you count once, you count twice, you show it to a colleague, he counts a couple of times. If in the end you are still with the ratio less than 2, but your HER2 numbers per cell is between 4 and 6, you call it negative. You might have, because then it is just a matter of chance for one count to be
above 6. Yeah.
Yes. Or the ratio to make it immediately above, because usually these ratios are immediately under 2.
Okay. So as you can see, while we in the previous workshop, we were looking at staining patterns and things like that, and we weren't paying too much attention about numbers, although numbers are important. Now, when we do DDISH, numbers rule, and we are counters now, being counters.
People who love mathematics, they will be thrilled.
Okay, and these you can go through the guidelines.
I think we talked very briefly about this.
Okay, this you talked about.
Yes, this was the before in 2002, but now the new guidelines have this update.
Fantastic. And this was the data that back up the fact that the group 2 really, I have a lot of responders in it. Okay, scoring the dish. How do we score the dish? That's why we are here. And this is very much, as you can see, a slide from the manufacturers. Because the manufacturers say you need to check the internal control, then you need to identify invasive carcinoma, then you need to count it. Okay. Yes, of course, we do need to check the internal control, because the dish is a delicate stain, and often you don't have the right staining. And therefore you think, no, just wait a moment, I'm not happy to interpret. So you do need to be much more wary of what you're looking at. Immunohistochemistry is kind of easy to spot that something has gone wrong. And we will talk about the fact that there are internal control on the slides you stain, on the section you stain, but it's also very good habit to put your own slide controls that are always the same, so you have an internal reference as well. Clearly, we need to score the invasive carcinoma.
Yes.
There's no doubt about it. Now, here is the thing that always puzzled me. Maybe somebody ought to come and turn the blip off. Just turn the blip. So here is something that always puzzled me. In immunohistochemistry, we say we need 10% of the cells staining with complete cell to call it 3+. All of a sudden, 10% has gone out of the window, and we just need 20 cells.
Yes.
So why? How does this work? Anyway, it's just a consideration. Okay.
I would assume they've done some not trials, but it is data that is backing it up. Like it's more sensitive like this, or it's more sensible to just count.
Maybe, and also maybe it depends very much on how do we approach this 20 cells count.
Yes,
and
that's
we can talk
big.
about it. Okay, so what do we need? We need some kind of counter. You can have a piece of paper, but it's tedious. You can have clickers. If those of you old enough remember when you used to do hematology differential white cell count, you had these clickers for each cell type. So you can find something like this, or nowadays you have an iPhone with an application. It's just good.
I'm still with paper and
Your
pen.
paper and pen.
Yeah,
That's fine.
still the old school.
Okay. Okay. So when we score, how do we choose which cell to count and which cell not to count? So theoretically, and I stress the fact it's theoretic because there will be sections where you will not be able to find ideal condition for scoring. Theoretically, you should avoid overlapping nuclei because there are clearly two cells, but I don't know whether this signal belongs to this cell or to this cell, so it's uncertain. I'll go and find something easier. On the other hand, you could take the point of view that these are two cells. I'll count all the red signals and all the black signals,
and you count those
by two. Anyway, clearly do not count cells without signal, or do not count cells that don't have both signals, either they only have red or they only have black. And don't count the signals that are sitting outside the nuclear envelope.
Yes.
Yeah.
Those are sometimes quite tricky.
Yeah, quite tricky. I agree. And then how to count. So this is 1 and 1. This is 2. But you see what I said about this could be quite big, but this is not a doublet. This is 1 and 1 and then 2. And now here you start to see doublets. We can be happy to call these doublets on black. And here you can see, for instance, a red and a black together. I can kind of differentiate between these two. These are still single signals. So, and here you start to see clusters. And some clusters are just black clusters. Some clusters have some red in it. Not surprising, since they're on chromosome 17, yeah? And some clusters are quite big. And then here you have a problem. Then while before you could count 1, 2, 3 as a cluster, 4 as a cluster. This cluster here, how many cells there are? I have no idea.
Yeah.
And there is a convention, you use your own convention, but usually the most important observation is that this is a cluster.
Those are the easiest.
This is amplified. That's amplified.
Those are the easiest.
Is it 20 or 15? I don't really care, to be honest with you. It's amplified, you know? Okay, fantastic. So these are clusters. And then be careful about background. Sometimes the silver gives a background. This is not particularly the best picture for it, but sometimes there is this very, very fine dust. So be worried. Don't start counting all these little dots. And sometimes there is this haze, red, pinkish haze. So do not start counting this shade. Just count.
I think this is more tricky.
Yeah.
to count just the signals that you see clearly in a cell.
And clearly you can say, let's not count the cell, but sometimes they are forced to, because these are, most of the cells are like this. So you need to, okay. So we spoke a little bit about polysomy, where you see these sea of red dots, sometimes with a bit of diffuse staining in the nuclear, within the nucleus. Is it polysomy? People who are much, much better than us at understanding these things say this is not polysomy, or very rarely will be polysomy. But anyway,
truly exists.
Yeah, that's it. So clearly, in an instance like this, you are going to struggle to make this carcinoma amplified on ratio, because there's a lot of red signals. I mean, you know,
that's why you have the more than 6.
The number of black dots can give you the amplification. And by the way, this is the corresponding HER2. You can see that is stronger than the staining. Okay. And there are some cases where in the same tumor, you have a clear distinction between what is not amplifying and what is amplifying. And you see what I mean about the fact that when there is amplification cluster, this is a Christmas tree, you know, are we going to start counting all these things? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
That's a very good point. That's a very good point. Unfortunately, I think some hospitals demand a count for their own internal data. So even if you see like these amplification clusters, in the end, what does it matter if it's 15 or 20 HER2 signals over there? You're saying it's full of amplification cluster. This case is positive. Sign it out. Don't waste time. Move on to the next case. Then you receive it back. No, can we please have a formal count for our data?
Because they need to enter the data into the central system, whatever, national database, etc., etc. Okay, so we need to provide a number, but you know, we can discuss this a little bit later when we see eyeballing rather than counting. So a case like this, what is it? Is it heterogeneous amplification? Is it mosaic? Obviously, immunohistochemistry would be important. Can I see what happens to the protein as well? So these are cases that are not really, really rare, but they are not common. So it deserves you to stop a little bit and think about it and approach it. Yeah.
I think these ones that, like in this picture, for example, when you have clearly not amplifying, clearly amplified, I think this could easily call it a mosaicism. And almost 2 different populations of cells. However, from my understanding, the heterogeneous is then when you have within a tumor cells that have amplification, cells that don't have amplification, they are mixed together. So then it is an interpretation, and I think we can talk even more maybe with some examples. So every single case, I think you need to think outside the box a little bit and take it. How old is the patient? How is the ER? How is the PR? How the tumor looks like? Everything taking all together.
Question for you. Why you want to know ER?
Because at the end, I want to show you a very interesting case that if I didn't know the ER and PR, I don't think I would have.
Okay.
I would have.
We'll wait.
It like that.
We'll wait. But you know, for me, ER is important because you know we know that in general, ER negative tumor with amplification have very broad responses, very long-lasting responses.
Good,
you know, it's an approximation. It depends very much on the patient population, et cetera, but in general, there is about 75% of responders in the ER negative population. If you look at the ER positive population, the responders are a bit less, like 50% if it goes well, and the extent of the response and the duration of response is less. So they are different tumors.
Yes.
That's right. Okay, fantastic. Okay, this is a case with a lot of amplification clusters and a lot of chromosome 17 sequence.
And see exactly what I was telling you. Sometimes it's different. See how many red dots you have even outside the cells.
Not to be counted, obviously.
Not to be counted. However, we can sleep night when we have this amplification cluster within the cell.
Yeah, so this is not very critical because we said we'll go on amplification cluster. And you can see here, for instance, this cell here, you say 1, 2, then there is a big black blob, which I think will be 4 or 5 signals. And then there is another one here. And then if you are very sharp, you find another one here on top of the chromosome 17 signal. So here there is more than 7%.
Well, according to the guidelines, the small clusters, you should count them as 6, and the large clusters, you should count them as 12. So that I would say that is more a small one, and I think I will count as 6.
Can I also say that how you count it depends on your microscope. You have a very, very good microscope. You can count more, and can resolve more. If you have a less good microscope, you have a big blob, and you have to.
But then I'm asking you, the slide that you put with the faint signals, if you have a microscope and you're starting moving the microVis, then you go into separate sections, a little bit of the cell. Layers. And then you are starting seeing signals that you didn't see previously. What are you doing? Are you counting all the signals?
Yes. So, and here that's a good question. The answer should be yes, if they are separate. And here we go into a consideration about the thickness of section, because obviously in the package insert say you need to cut at 5 microns, something like this, and 4 or 5 micron. Nobody has given me an explanation on why, and the explanation is always because we cut at 5 micron or 4 micron. And then I say, but in the UK, we cut at 3 microns. Oh, do you? Okay, but you should cut at 5 microns. And then you talk with people that done a lot of work on HER2, for instance, Joseph Rushov, and they say, Corrado, I always put 2 sections on my slide, one at 1 micron and one at 3 micron. Why? Because sometimes I can't score the 3 micron. It's too overlapping. I go to the 1 micron, and I can report. And then there is the other consideration. But why should we not have more signals the thicker the section? This has always been the concern. You need to cut it because you need to see all the signals. And those few people that have done some work, they haven't shown any difference. You cut thick, you cut thin, you have the same numbers. So, and this, I don't know why. Don't know what, but it happens also with immunohistochemistry.
Yes, it does.
I remember the work we did, and we used to cut even, that was PD-L1, and we were all preoccupied with this faint membrane staining, and we said, but if you cut thicker, you're going to see strong staining.
No.
No. It's the same score. So I don't know, and I don't pretend to understand these things, but
maybe someone from the audience now is going to enlighten us.
Yes.
Maybe
but
they're going to do a study about it.
But many times the 1 microsection has saved me because I
it's more clear.
Okay, so let's see next. Okay. This is something that's now very old. Look, Basel 2022.
How many European Congress have passed?
So you need to understand that we had COVID, and we were kind of twiddling our thumbs. We cleaned everything, played tennis or whatever it was, and then when no work to do, we did a lot of rescoring of HER2. Do you remember? We rescored thousands of slides again to look at the HER2 low, these type of things. Okay, and then another thing is say that this blooming DD issue. Why do we really need to count? We don't want to count. So you can tell them of this project.
So because like Corrado said, we had a lot of time on our hands. We retrieved all the biopsies from one hospital. There were consecutive biopsies, and we rescored them just by eyeballing. So we didn't count anything. And then we divided them into these 3 categories: the ones that had large amplification clusters, the one that had sparse HER2s, and the one borderline, non-amplified feature. That means I feel the need to count. With the large amplification clusters, I was happy to call, this is a clear positive case. With the sparse HER2 signals, that's a clear negative.
So clear positive, clear negative, and I'm not so sure.
Yes, we need to count them.
Okay, fantastic. So large amplification clusters.
That meant that only one case, I called it borderline, that I needed to count. And in the end, accord counting, it turned out out to be a positive case. So we didn't have not even one case that I called it negative and it was positive. No, okay, not even one. So we didn't lose any positive ones.
For the amplified, it worked very well.
Beautiful.
So what about the negative?
Was the same meaning. 126 cases, I was happy to call them negative from the beginning. One case, I called it borderline. I felt the need to count, and it turned out to be not amplified. So again, I didn't hold anything the other way around.
And then, of course, the borderline, some of them are amplified, some of them are not amplified, whatever. It doesn't matter.
Exactly.
Yes, of course.
A third, and third. Yeah.
But that means that out of, I don't know how many we did, 180 or something, 200 cases. For 155, we didn't have to count.
Yeah.
That means we can get on with life. We don't need to spend 20 minutes on
what I
the thing.
always like to say when we are presenting this and when we are mentioning is that we're presenting it at ECP, and it was also very well received because it was part of best breast posters, and many people were stopping by, and almost all of them said to me, but let's be honest, do you really count? And
they also didn't.
They also, and for me it was like,
okay, wow.
It's like, come on, of course I have already some numbers over there, and I'm picking from them each count. If it's negative, it's negative. It doesn't matter if the ratio is 1.5 or 1.4 or 1.3. Yeah. It's still negative. Okay. It's under 2.
But it's actually good to see that if you apply this system, you're not risking, you're not becoming dangerous.
But you need to be true to yourself. Okay. If you feel the need to count, if you're sure of what you're seeing, then
are we
you
going
count.
to show some cases that maybe positive, maybe negative, whatever. Negative cases. Okay. Or what do negative cases look like? Okay. It's a negative case.
This was a case that we were calling. So low HER2 signals, we were happy to call it not amplified.
Yeah. And it was not amplified.
And it was
once you counted, it was not amplified. This one also.
It was same.
This is what a negative case would look like.
Yes.
Very low number of HER2 signal, very low number of chromosome 17. Same.
So almost not even one single cell has 3 HER2 signals.
Maybe 1,
1, 2, 1, 2, 2, 1.
What the positive cases look like? Yeah. Why do you call this positive?
Well, look here. Look how many HER2 and chromosome. And this is more, not necessarily that has a lot of, it doesn't have amplification clusters. No. However, the chromosome is so low, 1 and 2, 1 and 2, and it's the HER2, it's always double.
Okay.
It's at least 4.
I understand. So while we are in it, can I ask you some questions? Yeah. This red signal here, on top of it.
Yes.
You count it or you not count it? Is it in or out?
It's an easy question because either way, that cell will be negative.
Okay, but
I think in theory, it's out. You should not count it. So even better, you're making it over there 5 HER2 with 1 chromosome 17.
What about this one here underneath my dot? You count it in?
That I would count. That I feel like it's more in than out.
This one?
I would count that one. Still.
And this one?
That's a more out.
Okay.
That's what my eyes are.
Okay. What about these
4? Those I wouldn't count.
They're out.
They're out from my point of view.
Now, this is an easy slide to interpret because the contrast with the nucleus is very good. There is good nuclear staining and the digestion wasn't very harsh. So there is still integrity of the nucleus. In this slide, you have the fibroblast, or what we call fibroblast. I don't know what they are. Anyway, they are stromal cells which have 1 and 1 or 2 and 2. These are your internal controls.
Yes.
Yeah? If you don't have signal in these things and you only have signals here, you need to reflect on whether you could score it or not. I don't know. Okay. But these little.
You don't have signals there and you have in the tumor.
Well,
that would be odd.
That is what they tell us, that the stromal cells is your internal control. You need to pay attention.
We did have these kind of cases where you don't have, but then even also the tumor cells are suffering, and then you're starting having the naked nuclei with no signals at all.
Okay. So, and then the other thing while we are here, we need to count 20 cells.
Yes.
Okay. Do we take this cell and then all the neighboring cells without leaving one behind? So this was I can tell you, this was what I thought we should be doing. This is what I was doing before, until I spoke to other pathologists, say, no, you pick up, you look at it and you think which ones are the representative cells here, and they're countable. Because, for instance, this one is clearly countable. I'm very happy. This one is overlapping, so maybe I should not count, etc. So this one I can count, etc., etc. So, and I pick up attach high power field 3, 4, 5, 6, but they need to be represented. They cannot just choose only the amplified ones.
That's the problem. Yeah. That's the problem. I think when you start picking and choosing the amplified ones, in that moment, you are prone to make not necessarily a mistake, because God knows if we are right or not. But from my point of view, you are about to call a case positive on a background that most of the cells are negative. And then that you are, in the end, you call the case positive, and that patient is going to receive a treatment, then God knows if it's going to work.
Yeah. Okay. So some comments about this. In general, patients without amplification clusters have much less chance to be responders. And there are much more chances to be low responders. So less extent of response, less duration as well. But nevertheless, the other thing is that, I always have these doubts. If I keep picking 1 or 2 cells per field, I'm making a case positive. So I try to do this, and then eventually you cannot keep it for 20 cells. Sooner or later, you need to include cells that will make this thing not amplified. This is really difficult, even by choosing to make it amplified.
I always said my approach is that I'm screening everything. I'm seeing if you will notice if it is a heterogeneity over there. Mosaics is not even to mention. You will notice this. But then I'm picking up fields where the cells are nice and easy, delimited, so it's quite easy to count. And I'm taking 3 cells from there, 3 cells from there, 3 cells from there, and so on until I'm making my 20. And I feel I'm quite impartial in my counting now.
Okay. Okay, that's another picture. What do we see now?
That's more easy because you have amplification clusters.
So small,
large. Some of them, they're quite large. Look, this one for me, this is a large one. Or just
maybe 1, 2, 3, 4, 5, 6, maybe in it.
I think more.
Maybe more. Okay. So here,
but you have amplification,
and a lot of the cells have these appearances, and you don't have too many red signals that may actually decrease the ratio.
Yes.
Okay. So this is easy amplified. What about this one?
It's again an easy amplified with amplification clusters.
Yeah. Okay. So here you have these things. Sometimes you have a thick, coarse silver signals. Sometimes you have very fine ones.
Yes.
Okay. But these are still countable. What do you think? Would you count all these little dots here?
But over there, you're missing the chromosome 17. I don't.
Here. Okay.
That's not a cell.
This is
like 2 cells.
Conglomerate. Yes. But let's say you wanted to count it. Are these 1, 2, 3, 4 signals, or you say, guys, this is too weak. I'm not counting it.
I would count. If that would be a 1 cell, but it's not 1 cell.
What about this cell? You see, it has these weak signals.
I would count.
They are countable.
I would count, especially the HER2, when you can see, even if it's a dot, but it's a clear dot. Yes.
So silver dots, we are much higher confidence in interpreting it. Okay. Now I find it easy. This amplified.
Yes, but still here you don't have quite amplification clusters. You're not there with amplification. You just have an increased number of HER2 signals per cell.
Okay, so this is another approach. You could, without counting, you can take 1 cell and say, is amplified or not amplified?
Yes.
For me, the amplification is either the ratio, or I have more than 6 or more seconds. So this one, clearly amplified. This one, clearly amplified. This one, clearly amplified. So you could accumulate in your head, amplify and amplify, not amplify. Amplify. So without even actually counting, just diagnosing each cell, amplified, not amplified.
Just to mention, though, in the project that we've done, we didn't, in the moment that you're starting making this counting in your head, that was, I need to count.
Okay, so unless
eyeballing was, I can see clusters, amplification clusters, Or I can see many HER2 signals that meant it's above 6.
Okay, and something
And it
like
was-
this, you would call it amplified.
Yes.
Yeah. Okay, very good. Same.
Yes, same.
Okay, this is what you say, must count.
Yes.
Okay. Yeah, there is
Yeah.
too many red signals.
In
Yeah?
the moment that you have many signals in one cell, red and black, you need to start
We need
counting.
to start counting. Unless you have an overwhelming amount of black dots.
Yes, unless,
Okay.
like we discussed, but
Yeah.
that if you have overwhelming, that you're already going into amplification clusters.
And this one, why must we count? This looks negative to me.
Because you are start searching for the HER2, which is very fine. The chromosome 17 is so big and there are so big blobs. And whenever we are seeing this,
distracts you.
yes.
Yeah?
And then look even here, you do have 1, 2, 3, 4. I don't know if it's the 5th, but still at least 4 of HER2. So black signals.
I can see now, and these black signals
Yeah,
very
they're
faint.
very faint, they're very fine.
They could be 6 per cell, in which
That's
case
the problem. So
okay.
you want to avoid
We need to
the
count.
missing, the positive case that you might miss.
Again, a lot of red signals. Basically, if there is a lot of red signal, we count. Huh?
A little bit.
A little bit.
Yes, a little bit, I think.
Why are we counting here?
How many black dots are you giving here?
1, 2, 3, maybe 4 actually, because there is one
Yes,
attached to the red.
and one chromosome.
Yeah.
So this you're making it amplify here?
Amplified.
Okay, but I don't know. What about here?
2 and 3 maybe, or 2 and 4, I'm not so sure.
Okay, but then you have this one, 2 and 2.
Yep.
And then you have this one, 2 and 2.
Yeah.
And then you have
So
this one,
amplified.
2 and 1.
Okay. So
And then you have this one amplified again, but then you're moving here and you have 2 and 1.
yeah. So okay.
So this is a mixture
Yeah.
of amplified cells and non-amplified cells. And how are you going to call it in the end?
Okay. What about this one?
This one, from my point of view, is the same. You
Yes.
have cells.
There are quite a few black dots, but
Yes.
not always 6.
Yes.
And then significant number of reds.
Yes.
Yeah. So we
And
need to count.
the black ones are either 4, 5, even 3, but
maybe 6. Some 1 or 2 are 6.
But when you're starting having 4 or 5,
Mm.
then if your chromosome is 2, you're making
That's
it
fine.
positive on the ratio.
Yeah.
And these kind of cases, they were in that borderline category that a third, they are becoming positive upon the ratio, but your ratio is going to be 2.1, 2.2, 2.3 is going to be a low level of amplification.
Okay. Time to try. Are we going to have a little poll? But I don't know whether we prepared the poll.
We can prepare.
We can. Anna is preparing the poll. What are we going to say, Paul?
Not amplified.
Must count.
Must count.
Okay. Anna is preparing it. Then she'll tell us. Let's have a look at the first slide, so you can start thinking about it. And when Anna is ready, she'll put the poll up.
And because I was just here next to my colleagues, next to Corrado and Ade, when they presented the HER2, I find a nice case. But unfortunately, it was not.
Okay, shall we look at?
Yes, that's beautiful. Yes. Yes.
Yep.
Okay, let's launch it.
Let's see what happens.
I will take my last 5 minutes to put.
Okay, what do you guys think? Positive, negative, or we need to count? I'm rubbish at this, so I will let you give us the answer.
I was literally thinking if you scored them with me or not, but I don't think so.
I can't remember.
I think we're doing another project.
Share results?
Yes.
Are you guys seeing this? Yeah.
See.
So most people thought it was positive, and a few people said must count. Nobody thought it was negative. Okay.
That's good. So regardless, everyone will win. I think this one, it is a positive case.
Must count?
No. I think it's a positive. You have amplification
because the
clusters.
amplification clusters.
Yes, and even when you do not have the amplification clusters, even these cells, you have more than 6.
Lots. Okay, good. Next one.
But please do interact with us. If you have any comments, you can either unmute yourself or just put it in the chat. Maybe you don't agree with our interpretation. That's fine. We can start counting together.
Okay, let's share results. No, share results. Yep. Okay, so
majority.
Most people thought it's negative, but a few people thought it was need to count.
I'd be curious for the people that say that they need to count. Why would they feel the need to count?
Yeah, you can unmute yourself and put it in the chat. So I look at it
from our perspective. It doesn't mean that.
So I look at it and I think this is not amplified.
Yes. A case like this, I would be comfortable putting it in the category of negative.
Negative.
You do not have, just look at your chromosome, pick any cell, 3 cells, not more. If you pick more than 3 cells, that means you feel the need to count. Just pick 3 cells. If those cells are not amplified, eyeball everything that the cells that you pick will resemble to the other ones. You do not have more or 3 signals of HER2.
Okay.
Regardless of the chromosome here. So you're never
negative.
going to make it positive.
I mean, of course, we're doing this as a game. It's just a picture. There is the whole slide.
Yes,
And this is the fact that you need to think about when you assess HER2 the issue. First of all, you need to look at all of the tumor.
That's
and then you pick up your area.
Always, always. Yes.
Okay.
Hold on. We have a reply.
Okay, very good.
Same here. I need to count because I need to report exactly. Yes, this is exactly what I said. Well, forget the I need to. Yes, try to. We don't. This game, we don't need to put the numbers.
But if we didn't have the statistician, let's say I need to put the number, would you count?
That's the question.
And you know, this is a useful exercise because then you will count, it doesn't matter. But it means that visually you're happier, you're not going to make a mistake.
Exactly. I think that's the most important for you when you are in those categories of I need to ask a colleague.
Shall we see what happens here? Shall we put a poll up here?
Yes.
Yep.
Yeah.
Thank you.
This for me is very reassuring.
This is controversial.
Yes. This is a beautiful.
Okay.
I think that everyone.
Let's share results. The results are, as you can see, quite a spread. Either positive, negative.
This says to me
what?
That you need to count.
You need to count.
Yes.
Yeah.
Definitely.
Now you tell me, what are your criteria here to need to count?
I need to count.
Yeah, I think there are a lot of red signals.
Yes. There are a lot of red signals. And then the rule of I'm picking 3 cells. I'm picking this one. I already have 4 black signals. 4 red. Okay, it's negative, but the 4 of black starts bothering me. If I have 2 or 3, that's fine. I'm happy to call it negative. Because the moment that I'm going into 4.
4 means I could be 6 and then.
Yes. And then it's like, can I find a cell with more than 4? And can I find a cell even that has 4 red, black signals, but 2 red signals? And then I'm making it positive on the ratio. So they're easy cells.
I understand. I look at it and I think to myself, this is not amplified, you know, in reality.
Please not.
But I understand that what you wanted to do is saying, I want to save 80% of the counting.
Look, this one. 1, 2, 3, 4, 5 black, 1, 2 red. Are you counting
maybe
this?
3, maybe 3.
Maybe 3, but this might be from this cell.
That's it.
So you don't know. If you're making it 5 with 2, you're making it positive. 5 with 3, you're making it negative.
This is 3 and 3. But I understand your principle that was, let's be safe.
Yeah.
I want to avoid counting and be safe. And so this one is, let's be safe, let's count.
Yes. Okay. And you've seen the split.
Because you are saving 80% of counting. Because you only counted 40 out of 200.
Exactly.
Yeah. So, okay.
This would be a case, where I would count.
Can I say count? Too many reds? Too many reds, and there are some amplified cells.
There are some amplified cells.
That's cells that I don't know what they are.
Yes.
Count.
That will be a count.
Yeah. Comments.
Comment.
Just a moment.
Oh,
Just a moment.
yes,
a moment.
please. No, the first cell looked like two overlapping to me. Yeah, probably.
Yes.
So we need to make sure.
This one, busy. Shall we see what people think? I think too many reds for me.
Yeah.
It's probably negative, but I think I should count.
Yes, exactly.
Yeah. I think I should count because I can see that there are some cells with a lot.
So we can share the results with them.
Yeah.
I wouldn't disagree with the people that say negative. Yes, I think it is a negative case. However, a case like this, I would count. Yeah.
In the context of being safe, because
Yes.
it's without counting. I don't know whether there are 6 signals here, silver signals in some of these things.
I know for the sake of the game, we put more tricky cases.
Are they
we took the tricky cases from our part, but you need to understand it in those 200 cases. That's the beautiful one that I had it like this. This is a perfect example of mosaicism.
Right.
This was tumor.
Amplified here, amplified clearly.
And for you to understand, the HER2 was identical. The HER2 was completely positive.
Yeah.
And I think it was 1+ of, maybe next time I will put the HER2,
when this picture came up, I thought, oh, but this is tumor. These are lymphocytes.
No,
but they're not lymphocytes. These are tumors.
It is tumor. Literally, you can see the split. It was a beautiful case. And we've done the dish for confirmation and for...
we have more cases? No. Okay, why don't we... That's very good. Thank you. Why don't you want to show that case?
That I have. And since most of the participants, I would assume that they attended also the HER2.
Yep. So this is relevant for them?
So this is relevant. This is like the summary of it's 2-in-1.
Okay, core biopsy and invasive carcinoma.
If correctly, was a high grade. I don't know how it was called.
So
ductal,
let's talk a little bit about morphology.
It could be even globular.
So if you have a low-grade tumor and you call it HER2 positive, you need to be careful because usually grade 1 and grade 2 are not positive. So, you need to pay attention to context. Yeah. Okay. So what's in here? This is a HER2. Shall we look at the HER2?
Yeah. Okay. So we receive it for HER2, reporting plus minus DDISH if we are saying HER2 to plus.
Okay. So clearly, basement membranes like staining or something, not convinced.
I would be curious what people would call this HER2. Hannah, can we do the poll with the HER2 this time? With the HER2. Hannah is doing her magic on the computer that we do not know. And this is still tumor.
Still tumor. Okay, so this is rubbish, doesn't matter.
And can you please score when you feel comfortable? Can you put a ×5 for me?
×5, yeah.
Yeah, is that?
×5.
Yeah. That's interesting. Yeah. Okay. That's fine. You can
×5. This is the area this is the problem area, yeah, I guess, because the others they don't show very much.
Exactly.
At ×5, I think I can see membrane staining. Oh, not continuous at all. So and poll and share.
But see how interesting.
Indeterminate or low.
I could agree with both parties here. Okay. I felt so this case we receive it. I did put a 2+, but for 2 considerations and one more than the other. Hold on.
No,
I'll leave it like that. It doesn't matter. For 2 considerations. One, you could see some lines at ×5. If you put again the ×5, I think you could see. But again, look how 1+ is for the rest, even negative, even 0 almost. I mean, you don't have staining almost. A case like this depends on the day, to be honest. Depends. I have some lines very much. The only thing that it really triggered me a lot to put it 2+ was that I read in the request form that we received, it was a high grade, don't remember, I think they have done, because it has some lobular features a little bit, so probably they've done icadrine, like it looks, I think, it was ICAD positive. Anyway, high-grade carcinoma, ER negative, PR negative. And that for me, it was like, oh, I can see lines at ×5. Let's like make sure it's not a HER2 positive.
Okay.
And like, and we have internal control over the HER2.
Okay, so
and look on that.
the
Yes, we just scan it again. So I hope it was. It's not brilliantly scanned because right now I put it on fast forward on scanning, so I don't think we scanned it with the right magnification.
1, 2, 3, 4, 5, and 1. A lot, and 2 at the most.
You even have amplification clusters.
Little amplification clusters. So how does this compare to the
And if
rest?
you look, yes.
It's all the same. It's all the same.
Couldn't believe it and then if you look, this is more important.
This is nice. Look, basically they are clustering. Okay, they're not huge, but they're clustering.
Again, we apologize for the scanning. It's not perfect. Usually we are putting with a high resolution and it takes a little bit longer to be scanned. This was scanned in less than a minute.
But
it's not brilliant.
They are clustering.
If you zoom out and you go on the other core, this core, that it was completely negative. This is what my fear was, that, oh, maybe I have a mosaicism or heterogeneity of the tumor.
Not really.
Not really.
So this was then maybe a failure of immunohistochemistry, or maybe this is the tumor. The tumor doesn't express so much.
And that's
but I think there is a lot of stuff here that is not really right.
That's why I started saying you need to think in the context.
Yeah.
And there were hints here because, again, if you put a ×5, you have lines.
A line.
You do have lines. So on that basic, if you follow the algorithm that Corrado and Ade presented, ×5, you see lines, you're putting it for the D-dish.
Yeah, it's not beautifully preserved.
It's not.
Is it?
No, yeah, could this be an example of poor pre-analytics?
Maybe.
Maybe.
I think if it was ER, I don't know. If you're asking me now,
if the question is if the expression is real like this and is amplified, then are we looking for amplification in cases like this, or would we rely on
the immuno
future HER2 low status and
let's stop sharing. So that's an interesting question. That's an interesting question. Before the availability of this drug, antibody conjugate, these antibody drug conjugates, these patients either had an HER2 plus chemotherapy or panitumumab or whatever, not an HER2, sorry, trastuzumab, or had just chemotherapy. And so there was no plan B for them.
Yeah.
And now there is a plan B, which is the antibody drug conjugate. And some people are starting to say, I'm not so sure that trastuzumab plus chemotherapy is as effective as an HER2 in certain circumstances. So yes, the landscape is shifting. We haven't got results of some of these trials. They've already compared for HER2 positive tumors, the amplified tumors, escaping trastuzumab, that HER2 is much more effective than Kadcyla. So now is the treatment of choice for those that escape trastuzumab. So this is in evolution, and the context would be changing, but yes. Okay, so that's it. So we have 2 circulations now, one for immunohistochemistry, one for the dish. And then we'll see you all for feedback meetings on 8th of October. Very good. Thank you very much.
Thank you.